Good evening, sir.
Good evening, Umar. Good evening.
Yeah, okay. Sir, okay, sir.
Okay. Much better.
Okay, sir. Okay.
Sir, you can start.
Yeah. I'll wait for 2 more minutes.
Okay,
Before
sir.
joining.
Sir, good evening.
Good evening, Rajesh. Good evening.
Rajesh അല്ല സാറേ മോഹൻ
എന്റെ പടം കണ്ടില്ല അതാണ്.
ഞാൻ പടം ഞാൻ വീഡിയോ കട്ട് ചെയ്ത് വെച്ച.
Okay. അല്ല, it is written Rajesh iPad. Your name has changed.
അതല്ല സാറേ, അതെന്താ അറിയോ, സംബഡി പ്രസന്റഡ് മീ, അപ്പൊ അയാളെ പേരെന്തോ അങ്ങനെ
Okay, right.
iPad.
Okay.
പിന്നെ അങ്ങനെ ഹെൽത്ത് ഒക്കെ അങ്ങനെ പോകുന്നല്ലേ സാറേ?
Pardon? Health is okay. Yeah, much better now. It's better. Just 1 more minute will go, okay? Usually we wait for 2 minutes. It's already 8:15. 1 more minute. Okay, we'll start. Smita, shall I start?
Yes, sir.
Yeah. So, good evening to all of you. I think this is the 114th session on this challenging case series. I will share my screen. Is my screen visible to you all?
Yes, sir. Put it on slideshow.
Okay.
Yes,
So
sir.
this-
Got it.
Yeah. This is the story of a 21-year-old female. Her complaint started at the age of 17 as imbalance while walking. Initially, the patient was walking with the support of one wall by herself. However, 6 months later, her ataxia progressed to the extent that the patient required support of 2 persons to walk. That again progressed, and presently, patient is in a wheelchair. 6 months later, patient noticed difficulty in writing and was noticed to have mild dysarthria as well. This is a story. No positive family history of similar illness. So complaint started about 17 years. It is now 21. That is about 4 years from the onset. Progressive imbalance while walking to the extent that patient became wheelchair bound in 4 years' time. In addition, she has difficulty in writing and mild dysarthria as well. No positive family history of similar illness. So this is the video of the patient. The pupils were normal. One day were normal. There was no RP or cataract.
ഇടത്തോട്ടെ
Yes, sir.
മുകളില്
There was no,
താഴെ
there is no swelling of the second.
കണ്ണ് മുറുക്കി അടിച്ച മോളെ
Failures are all normal.
പല്ലി കാണിച്ച് തുറക്ക് ആ നിന്ന് പറഞ്ഞു ആ
The speech is
I can eat it.
electronic, it is something electrical speech.
പിടിച്ച് ചെയ്യേ മതി. ഞാൻ പറഞ്ഞ പോലെ പറയണമേ. ഞാനിപ്പോൾ തിരുവനന്തപുരത്താണ് താമസിക്കുന്നതെന്ന് പറഞ്ഞു. ഉറക്കെ പറ. ഒന്നിനു പറഞ്ഞു.
ഞാനിപ്പോ തിരുവനന്തപുരത്താണ് താമസിക്കുന്നത്.
ഒന്ന് തിരിച്ച് പിടിച്ചു ഇങ്ങോട്ട്
But a brief voice and
കിട്ടാം.
is normal. It seems mild wasting of the small muscles in the hand. We first use Neurology. We are not very certain because she's got a thin build. Seems to be mild spasticity of the finger extents, finger flexors. Do like there's some spasticity could be in the distal part of the fingers.
കൽപ്പിച്ച് പിടിച്ചോ.
Our deltoid was normal.
കൈ അകത്തോട്ട് മടക്കി പിടിച്ച്
Biceps normal.
പിടിച്ച് നൂർത്തെ
Our was all generally normal.
വിട്ടെ. എൻ്റെ കയ്യിൽ നിന്ന് മുറുക്കി പിടി. മാക്സിമം പിടി. മതി വിട്ടോ. തിരിഞ്ഞ് മുറുക്കി പിടിക്കുക. വിട്ടെ. പിടിച്ചോ. ആറ്റി പിടിച്ചോ. ആറ്റി പിടിച്ചേ. പിടിച്ചോണ്ടിരിക്കും. ആറ്റി പിടി. ഒന്നുകൂടെ നൂർക്ക്. ഇത് നൂർത്തെ. കേട്ടോ. ഇതിനെ എങ്ങനെ പിടിച്ചേ?
Whether there was mild weakness is present or not, I'm not sure. But could be there might be. Since it's symmetrical, I cannot comment on it. But undoubtedly, she has got incoordination of both upper limbs.
മൂക്കിൻ്റെ അറ്റത്തോടും കൂടെ
Little more
ഒന്നുകൂടെ ചെയ്ത്.
prominent on the left side than on the right
ഈ
side.
വന്തികയുടെ ഒന്നുകൂടെ ചെയ്ത്. ശരി, ഇനി കൈ ഇങ്ങനെ നീട്ടി പിടിച്ചേ.
There is no pseudoantithesis per se.
കയ്യിലോട്ട് നോക്കുമോ? കയ്യിൽ ഇങ്ങനെ പിടിക്കാൻ പറ്റും. ഇങ്ങനെ പിടിച്ച് നിർത്തണേ. നമ്മളെ കൈ നോക്കിക്കോണേ. കയ്യിൽ നോക്കിക്കൊണ്ടേ ഇരിക്കണം കേട്ടോ മോളെ.
It's also got multiple to the head.
നോക്കിക്കൊണ്ടേ ഇരിക്കണേ. ഇനി കണ്ണം കടച്ചു. കണ്ണ് തുറക്കല്ലേ.
Only one is normal.
കുടക്കല്ലേ മോളെ.
Suspicious person with the left lobe.
എത്താൻ നോക്കിയിട്ട് എത്താൻ നോക്കുമോളെ. ആ ശ്രമിക്കാം. വെരി ഗുഡ്. ആ അത് തന്നെ. അതേപോലെ തന്നെ പിടിച്ച് നിർത്തുക. ഒറ്റ സെക്കൻഡ് പിടിക്കും. മതി മതി മതി. ചോട്ടി മാറ്റി പിടിക്കും. അതേപോലെ ചോട്ടി മാറ്റുക. ചോട്ടി മാറ്റി മാറ്റി മതി. അത് തന്നെ. ഇത് പിടിച്ച് നിർത്തുക.
100%.
എന്നിട്ട് കൈ ചവിട്ട് ചവിട്ട്. മതി. ഈ തണ്ടവരിൽ പൊക്കി പിടിച്ച് മുകളിലോട്ട് പിടിക്കുക. ഇത് പിടിച്ചോ. മതി വിട്ടോ. ഇങ്ങനെ പറ്റും നോക്കട്ടെ മോളെ. ആ
Initially incontinence by that.
ഇനി കൊണ്ടുവന്നേ. ഇതിന് മുകളിൽ വെക്കും. നോക്കട്ടെ. താഴെ കൊണ്ടുപോവാ. ശരി മതി മതി. അതേപോലെ ഈ കാര്യം ചെയ്യാൻ നോക്കിക്കേ. നോക്കി ശ്രമിച്ചേ. നോക്കട്ടെ. ഞാൻ നിൽക്കുന്നു.
Very important.
ശരി മതി.
Plus, the upper limbs were all normal.
മുട്ടും.
Index with disc bilaterally. Our angle were absent. Just checking. And there was undoubtedly upgoing bilateral.
പുഴയിൽ കുത്തുമ്പോഴേ ഇതൊക്കെ ഒരേപോലെ അറിയാമല്ലോ.
Were all normal.
ഒന്നേ തന്നെ.
Is it correctly? She could able to count correctly.
നമുക്ക് ഇപ്പം എന്തെങ്കിലും തോന്നുന്നുണ്ടോ?
Bilateral is also normal.
കിരീടം ഇപ്പോൾ ഉണ്ടോ?
Yes.
അവിടെ ഇല്ല. ഇപ്പോഴോ?
Able to feel out throat.
അവിടെ ഇല്ല. ഇപ്പോഴോ? ഇപ്പോഴോ? ഇപ്പോഴേ? ഈ ചെറുവിരലി പറയാം. ഇപ്പോഴും ഇപ്പോഴും അതേമാതിരി കാലി പറയാം. ഇപ്പോഴും അറിഞ്ഞൂടാ. അറിഞ്ഞൂന്ന് പറയും. ഇപ്പം നമ്മളെ അറിഞ്ഞൂടാ. ഇപ്പോഴോ ഇപ്പോഴാ എനിക്ക് കേൾക്കുന്നില്ല. ഇപ്പോഴോ
is grossly attached. So mild spasticity of the left lower limb. We'll put some dragging there. If that spasticity seems to be there on the left side. That will go. There attacks here.
കൈവിട്ടോ.
See, even otherwise, stance is clearly abnormal. So, an examination, high function is normal, cranial nerves frontae normal, saccades normal, speech, hypoponic speech, motor, tone, mild spasticity of the finger flexors and corticeps. Left lower limb also is slightly spastic, maybe right lower limb as well. Overall, grossly normal. DTR all normal in the upper limb. Knee jacks brisk bilaterally. Ankle jacks diminished or absent. Abdominal progest elicitable. Plantar upgoing. Sensory system touch, pain, vibration normal in the upper and lower limb. Impaired JPS or both toes. Bilateral finger nose and heel shin incoordination. Severe stance and gait ataxia for his spasticity of the left lower limb. So, what do you think the possibilities in this patient?
Frederick's ataxia, sir.
Okay, very good possibility. But usually they start at the age of 17 now. Usually Frederick's slightly earlier onset, no? But that's a good possibility. Yes.
Vitamin B12.
Pardon?
B12 deficiency.
Yeah, B12 deficiency is one all treatable condition you have to keep in mind, like B12 deficiency. You can produce attack cerebellar involvement. Sensory can also pyramidal or can occur with B12 deficiency.
Ursax can be Ursax.
That's the key feature is a severe spasticity. Here limb is spastic, okay, but can still keep that possibility. That all can be that possibility. Agreed.
Early onset SCA, sir.
Pardon?
Early onset SCA.
Early onset SC is also possible, correct? So there are many possibilities.
CBJ anomaly.
Spastic attacks.
Pardon?
CBJ anomaly.
CBJ anomaly seems less likely because, okay, the speech abnormality is uncommon or very rare in CBJ anomaly. But if you explain, see, patients got hypoponic speech, if you think that can be due to some, say, tentative involvement, yes, that's a possibility. But parietal movement were all normal. Usually cannot be affected in ACM.
Yeah, angle jerk was impaired.
And angle check was impaired. That's another strong point against CBJ anomaly. Correct, perfectly right.
Can this be some sort of spinocerebellar ataxia? Maybe
Possible.
vitamin E responsive or something.
Yeah, there's vitamin E deficiency, copper deficiency can present like that. Like an posterior column posterolateral syndrome with, but these patients could see with cerebellar ataxia also. Not
Hereditary spastic attacks.
Yeah, it's a spastic ataxia syndrome.
Can it be SPG7 related?
Yeah, but here the cerebellar involvement is more dominant rather than spasticity. So I think some kind of a cerebellar syndrome, hereditary cerebellar ataxia, or some other metabolic cause like vitamin B12 deficiency, vitamin E, copper deficiency. Those
What
things.
is SPJ7?
Pardon?
What is SPJ7?
It's one type of spastic paraplegia. I don't know what the other features of SPJ7.
Sir, she has a peripheral neuropathy in addition to the spinocerebellar syndrome. She has got spasticity, bilateral cerebellar, and peripheral neuropathy.
In SPJ, spastic paraplegia can be various types. They can have peripheral neuropathy, they can have bladder involvement, they can have cerebellar involvement. So there are any number of SPJ types. One cannot remember which are the clinical features of each. Okay, so this came with these investigations, were treated in some other hospital, and this investigation done elsewhere. This is the blood chemistry. ESR was 9. There is no gross abnormality in the blood chemistry. They did ANA profile was negative, TPO was negative, thyroglobulin negative, GAD was done, which is also negative. Their TTG, that is for the celiac disease, was negative. Intramycin antibody negative, alpha fetoprotein negative, visual acuity normal, visual VEP normal latency. NCA they reported as normal study. Ophthalmic evaluation, no reiterated spot maculopathy or pigmented retinopathy. Peripheral spare microscopic hypochromic anemia. Serum ferritin was however low. MRI brain done outside with mild superior vermin atrophy, rest of the brain parenchyma normal. So this is the report of investigation done from elsewhere before it came to our hospital. Then they did also CSF, which was essentially within normal limits. So with this background investigation, what is the likelihood?
Again, Fredericks versus early onset SCA, sir.
Yeah, SCA. Okay.
Versus early Fredericks ataxia, sir.
Okay, right. But the point against Fredericks ataxia is that patients got reported to show superior vermin atrophy.
And the posterior column also fairly normal in this case. So that also against that, sir.
Well, posterior column is affected in this patient. JP
No, it's only mildly affected compared to in Fredericks. We expect more of more posterior column as well as the optic atrophy and everything.
That need not necessarily be there because, as you correctly said, ataxia in Fredericks is due to the spinocerebellar tract involvement rather than due to the posterior column involvement. They can have peripheral neuropathy as well as cerebellar ataxia, true cerebellar ataxia, without any posterior column impairment in Fredericks due to the spinocerebellar tract involvement in the cervical column, which are destined to go to the cerebellum. So they may not have impaired joint sense in the upper limb syndrome.
Spine is normal, sir. Any scoliosis or kyphosis?
No scoliosis, no scoliosis or any press cavus. In fact,
So what about nerve conduction?
Repeated infection also.
Nerve conduction, sir.
Nerve condition, it's written normal study here. This is
Serum copper deficiency. Serum copper.
Copper they have not done. So we'll do that. Okay, this is what said. So what will you like to do in this patient?
B12 and vitamin E as well as serum copper, sir.
Okay, vitamin E and serum copper. Okay, very good. So first thing I did. Yeah, repeat NCS has to be done first of all.
Almost 16. Almost 16 will be better.
Let us see the nerve conduction was done. Initially, they reported as initially normal, but what we did was his absent superficial peroneal and bilaterally, and sural amplitude is also low. So patient has in fact mild sensory neuropathy affecting the lower limb. Right, FA with latency was normal. Now what else you need? You said this vitamin B12. Say repeat MRI was done. Why repeat MRI was done in this patient? Because that's very crucial. Because if it is Fredericks ataxia, you don't expect any cerebellar atrophy. On the other hand, if it is some other cerebellar degeneration, like other SCA as spinocerebellar ataxias, or due to some conditions like Sachs syndrome, as somebody was mentioning, you expect some cerebellar atrophy. Okay, but here in Fredericks, you don't expect any cerebellar atrophy. So as I said in MRI, this is MRI in this patient, which we did here. This is the lower spinal cord, brainstem, medulla, pons, and cerebellum. This is the midbrain region and the occipital lobe, and the vermis also you can see there. The uppercut. This is the axial T2. This is a sagittal cut. So, what do you think after MRI?
Not much atrophy.
Yeah, no.
Superior vermi atrophy, sir.
This can be normal, quite normal. Very often we see this now. See, for example, if you take axial cut also, the superior vermi cell show. See, this is all. See, the superior is quite normal. So, what else you need? So, cervical spine was done. Why cervical spine? Look for any atrophy of the cervical cord, suspecting a petrous ataxia. So, this is cervical cord. Then repeated cervical cord. This is a sagittal, axial. So, what do you think?
Metabolic cause.
Do you think there is a cervical cord atrophy or not?
There is atrophy.
Yeah, there is atrophy. No, I'll show that this is the comparison. This is the left side is the patient's MRI. The right side is the normal person's MRI of the same age. There is definitely atrophy of the cord, not very gross, but mild atrophy. Our patient is atrophy here on the left side. On the right side is the normal cervical cord at that same level. See, the level is same, and the axis level of the axis C2. This is again lower down. Again, there is some atrophy you can see. So there is, if you compare with the normal MRI, this seems to be atrophy. Otherwise, we just look at the MRI, we think it is normal. Because why I did was because we strongly suspected a petrous ataxia is one possibility. Since cerebellum is normal. In any other ataxia, progressive ataxia, degenerative ataxia, you expect cerebellar atrophy to occur, except that due to the spinocerebellar tract involvement in the cerebellum. So that is why we concentrate on the cervical cord. So what else you want to do now?
Genetic study. Genome sequencing.
Yeah.
Genetic study.
Before that, I asked about the family history. There's no family history. She's born of consanguineous parentage. So she had another younger sister. I examined the younger sister. Who is 13-year-old. She's clinically normal. So these vitamin B, as you said, vitamin B12, homocysteine, vitamin level were all sent. And the repeat expansion genetic study was also sent. And this is genetic study came first. This is showing a petrous ataxia. So the point, I think great in this case, you all diagnose petrous ataxia. Only thing is when normal cerebellum, if you have normal cerebellum or no atrophy in the cerebellum, keep this possibility strong in the back of the mind. Cerebellar atrophy is the host of so many other conditions which come with the differential diagnosis.
So, sir, can they have this sort of this much severe attacks in Frederick, sir?
Of course, they can have, because severe attacks can occur in Frederick's attacks to the extent they're totally unable to walk.
Sir, one doubt.
Yeah, please.
Sir, if you're having an alcoholic who has developed cerebellar signs, is it possible that if there is no cerebellar atrophy, Vermean atrophy on the structurally, it is not there? Should we think away from alcohol in cerebellar disease?
Not necessarily, because the atrophy comes only later on. But the point is, in alcoholic cerebellar atrophy, the affection is on the superior vermis only. It's only going to produce gait ataxia, not speech involvement or upper limb incoordination.
Sir, sorry that your voice got blocked out. Could you please explain?
I'll repeat it. In alcoholic cerebellar degeneration, it is confined to the anterior lobe of the cerebellum or the superior vermis of the cerebellum.
Okay,
So
sir.
it produces a gait ataxia. Upper limb incoordination and speech will not be affected in alcoholic cerebellar degeneration.
Correct, sir.
Yeah, that is one clinical point.
Yes.
Expect atrophy, but as you said, in early phases, you may not get an atrophy of the cerebellum.
Okay, okay. But if there is a florid lower limb gait ataxia, predominant gait ataxia,
Definitely you have to keep that possibility
in mind. Even if there is no structural lesion seen on the MRI, if there is no atrophy visualized, also we can think of alcohol induced.
Yeah, you should think of that possibility.
Oh, okay, okay, sir. Thank you.
How to explain spasticity, sir?
Pardon?
How to explain the spasticity, mild spasticity?
Yeah, they were in pyramidal lesion, pyramidal dysfunction can occur in vertex ataxia.
Okay.
Ataxia, the findings are absent angle jack with upgoing plantar and spasticity.
Okay.
That varies. Some of the vertex ataxia patients have no spasticity. See, all reflexes may be lost. Every reflex may be lost. Some of them can only angle jack lost, as in our patient. So that the relative affection of the various tracts, the spinocerebellar tract and the pyramidal tract, can vary from individual to individual. Some of the vertex ataxia can have extrapyramidal involvement.
Sir, one doubt, sir. In sporadic ataxia, there is dysarthria, no?
Yeah.
Now, this dysarthria is a combined spastic and but because superior the cerebellar tract, spinocerebellar tract is involved, so there should not be any dysarthria. So, is the dysarthria in Friedreich ataxia is spastic?
No, I'll tell you.
Or is a combined one?
No, I'll tell you that this doubt I had when I started studying from the very beginning when I was studying for DM also, I had the same doubt as you said. No, they say cerebellar atrophy is not there, but how can this patient have nystagmus? They can have nystagmus. They can have true cerebellar dysarthria. Okay, in vertex ataxia. But that comes later on, not in the early phase, cerebellar ataxia and nystagmus. So they can have some square wave abnormality can occur earlier. Still, it is what you said is perfectly right. It's still not very clear why these symptoms, how to explain these symptoms in the presence of a relatively well-preserved cerebellum. But they can get affected later on in the course of illness. And one more point, the previous answer to the previous question. So in late onset late onset FA, vertex ataxia, they can have brisk reflexes all throughout the lower limb and spasticity. They can have in the vertex ataxia retained reflexes.
Okay, sir.
They can have spasticity and all reflexes may be brisk with minimal sensory or no sensory. That can have a spastic variety of vertex ataxia.
This girl has dysarthria, sir.
This actually, it's not a true cerebellar disorder, only hypophonia was there.
Okay, sir.
Last week in that pediatric meeting, they presented a case of vertex ataxia. That girl had severe cerebellar ataxia, scanning speech, eye movement abnormality in the form of square wave jerks and macrosaccadic oscillation, and normal cerebellum in the MRI. But severe incoordination upper and lower. So definitely it's affected. Why? So they will not.
Sir, we expect some scoliosis, pes cavus, or other abnormalities in this case.
Yeah, but that tells you that phenotypic variability in vertex ataxia. Because I told before, some of them had only predominant spasticity, some predominantly. That girl which I told just now had all reflexes were absent. And the ataxia was cerebellar ataxia. Conduction was not that closely abnormal. So the phenotypic expression can vary, both the skeletal and extraskeletal abnormalities.
So you did CAG repeats. Now instead of that, can we do complete genome sequencing, sir? When
No,
we don't know the diagnosis.
Yeah, that because if you're suspecting fertility attacks, you have to go for this sequence, CTG. I mean, trinucleotide repeat sequence. Otherwise, you will. If you do the clinical exome, you will miss these things. I don't know too much about genetics, but the little knowledge I know this. For sequencing, you have to do specifically this one. If you send for clinical exome, you will miss these diagnosis.
If we suspect SCSR scar, then we have to do trinucleotide or genome sequencing. So which one is better?
Again, not genome sequence. You have to do the CA panel that include the repeat sequences.
Because last time you presented one case, it was negative in trinucleotide but positive in genome sequencing.
Yeah, that's correct. Some of them do come like that. And that particular patient was a mitochondrial cytopathy, Golgi mutation, and not honorary SCA. The one which you were referring to was SCA panel was negative, but with a clinical sequencing came out to be Golgi mutation. That's a mitochondrial gene. For Golgi, of course, you can do clinical exome. Because mitochondrial panel and clinical exome, they do the mitochondrial panel, they do it freely if you do the clinical exome sequence.
Sure, here before genetic testing, can we consider mitochondrial cytopathy also in DD?
Yeah, clinically, of course, it can fit in with that also. Nothing against it. But there is no abnormality in the MRI to suggest any mitochondrial disease. Okay, shall we go to the next case? Okay, this is a 35-year-old, this is 5 or 6 similar cases, all with different presentations. 2 of the cases belongs to Dr. Joy. This is a 35-year-old lady. Her complaints of tremor of the whole body while standing, sitting in the stool, but not present while seated in the chair or while walking for the last 5 years. So it's present while standing, present while sitting in the stool, but not seated in the chair. Let me see the video. No positive family history. This is the lady who is sitting in the stool and she has got a tremor like tremor versus myoclonic. They're not a fast frequency tremor, more like a myoclonic.
இப்போ இருக்கும்போது நிக்கும்போது ஜாஸ்தி வருது ஆனா நடந்தா கம்மி
ஆமா இதே போல ஸ்டூல்ல இருந்தாலும் இருக்காது
இருக்கு
Look at that tremor myoclonic.
அங்க நிக்கணும் எந்திரிங்க
When I stand, also still
அங்க நீங்க அங்க நில்லு கொஞ்சம் ஜாஸ்தியா வரைக்குது இல்ல
it is more while standing.
இல்ல நிமிஷம் தேங்க் யூ வெரி மச் இந்த விரல சொன்னீங்கன்னா
It is not there while walking.
திரும்பி வாங்கம்மா திரும்பி வாங்க ஸ்பீட்ல வாங்க இன்னொரு தடவை பார்க்க முட்டிச்சு முட்டி அப்படி
There is no
நடங்க
gait ataxia and walk is also normal.
கை பிடிக்காம
It's only one
நடங்க இல்லன்னு நடக்கும்போது இருக்கேன் கொஞ்சம்
She is able to sit in that chair, there is no tremor.
கால் நீட்டி வைங்க தாத்து அப்படி
She said when I seated in a stool, she will get the tremor like the myoclonic chair. Then media is in the stool.
கால் கொஞ்சம் நீட்டி வைங்க அப்படி
Changing the position also did not sit in it very myoclonic.
இன்னியம்மா இந்த ஸ்டூல்ல இருங்க
When you sit in the stool, it starts getting that abnormal.
அப்படி நேரம் அப்படி வச்சு கை பிடிக்க சும்மா இருங்க அப்படி வச்சு சரி இனி மறுபடியும் அங்கே இருங்க
again disappears while sitting in this chair. Okay. Now look at outstretched down, but like movement down.
இப்படி நீட்டி இப்படி வெள்ளாச்சு அப்படி வைங்க. இப்படி வேறு இப்படி இருக்கு. ശരി, ഞാൻ വിരലിന്റെ തൊട്ട് മൂക്കിലെ തൊട്ട് മറ്റേ കൈനാല് മറ്റേ കൈനാല്
താക്കോലവിടെ വെച്ചിട്ടുണ്ട്. താക്കോലവിടെ വെച്ചിട്ടുണ്ട്. Sorry. So in the past, she was tried on beta blockers, clonazepam, mycilline, pacitine with no relief. This is the tomograph done from outside. I do not know how to interpret those things. So, what do you like to do in this patient? What do you think the patient was having?
Orthostatic tremor, sir.
Yeah, orthostatic tremor or a orthostatic myoclonus, correct? But
yes, sir. It looks like a primary orthostatic myoclonus, sir.
But why should it occur while sitting then? Is it sitting in the stool, not in the sitting in the chair?
Proprioceptive, some stimulation.
Okay, something to do with the problem. But or something else. Okay, let's come to the another case. So she was put on, what I did is put on high dose of clonazepam, and this is the follow-up of the patient. Relatively high dose, stiff dose. She was 2 milligram BD. Myoclonus disappeared. This orthostatic myoclonus. Okay. And I will show another case. This lady has presented the history of tremulousness of both legs while bending down, not when she was standing. So, for example, look at this girl. But standing, she has no myoclonus. Must get bent down. She started having myoclonic. Breathing is functional. Okay. So this is
That also proprioceptive.
okay.
Related with that.
But what proprioception? Why is it occur while on bending down? It is occurring. It should be there all the time.
Could be a positional tremor.
It's a specific action myoclonus, sir.
Okay, specific action background. Okay, let us see. Now, this is 56-year-old man came with the history of tremor of both limbs while sitting, lifting the legs while lying, but less on walking, but feels mild imbalance while walking for 2 years. And so this person, where he was sitting, gross jerky, not like a tremor, irregular jerky movement, like something like a myoclonus. He said it's not present much by walking. There is no involvement of the hand, nor the speech. He's sitting there with the leg support on the stool. He's got a mild tremor-like movement on the left side. When he asks to lift up the right leg, it increases. Also starts appearing on the right leg as when he lifts it up. He starts appearing the right leg as. Lift up the right leg, start tremor appearing on the left side. But standing it is there. But on walking it disappears. No problem in walking. Now, this patient was put on Pacitin, no improvement, was put on clonazepam 2 weeks after treatment. Not totally subside, but remarkably improved. So these are all variants of so-called orthostatic myoclonus. Tell you what ideally should call that later. The bending down it appears again.
സ്പീഡ് നടന്നു പോകണം, സ്പീഡ് നടക്കണം, അതിന് തിരിച്ച് നല്ല സ്പീഡ് നടന്നേ.
This is Joy's case, Joy's first case. This man had tremor-like movement when he stands with the forefoot elevated, pressed on the brick here. It will not be, it is much less when he stands on the flat with the feet on the floor. If he has got tremor-like movement. That position becomes scary. Stand like that, there's not much of a tremor at all. Okay, another case from Joy. Also got tremor-like movements of the foot. But on lifting up, it becomes more severe, high amplitude involving the whole foot, sometimes the leg also. Not present on the left side. Not present on the head. With feet supported on the floor, it is not there. But it has to lift up the angle, it comes. It's lifting up the angle, standing, pressure on the bone interface. And the heel touches the ground, disappears. Lying flat in the mid-outside is not there. Now, what do these cases tell you? Because here the tremor or the myoclonus appears when certain muscles are put into action, correct? Whether it is standing or it is lying down or bending down. So not present all the time. When the muscles are put into some action or that appears, the tremor appears. And when the muscle is relaxed, it disappears. It need not necessarily be while standing, it may be while bending or sitting in a stool. So the muscle activated on sitting stool is different from a chair. So it varies from individual to individual. So actually this orthostatic myoclonus is a misnomer. It should not be, it should not ideally be called orthostatic because it's not always related to orthostatism. It's not always present when it is standing, as you've already seen here. Sitting in the stool or bending, it appears. The Joy's case, only when the forefoot is elevated, comes the first person. Second, when the plantar flex position, it appears. So it's all occurs in relation to some stretching of the particular muscles. So it's called myoclonus specified by isometric contraction of the muscles. So it should ideally be called as isometric myoclonus, isometric tremor. Some orthostatic tremor patients can also report arm, head, or rarely even jaw tremor on standing. Lower limb symptoms in both orthostatic tremor and orthostatic myoclonus attenuate or extinguish when affected patients lean on an object, when the muscles are relaxed. Both orthostatic tremor and myoclonus can transmit to arm after the patient leans on an object. So, moreover, these have been reported without an upright posture at all, as we have already seen. For example, tremor can occur in the arms and legs when the patient is on all fours, or when affected individuals contract their muscles against resistance while sitting or lying supine, as you already seen. Joy's case is putting resistance again when they contract against resistance, it appears. So consistent with isometric phenomenon rather than a purely orthostatic one. That is where some of these patients had myoclonus when bending or on stretching the calf muscles. So that's a so you are going to see such case here again. But these all patients all respond to the same treatment for those orthostatic tremor, like a high dose of clonazepam. So any questions? Am I audible?
Sir, what is it?
Yeah, please.
Sir,
Yeah.
what is the spinal segmental myoclonus?
The spinal myoclonus can be of two types. Spinal segmental myoclonus, other is the proprioceptive myoclonus. Segmental myoclonus is confined to only one or two contiguous segments, muscle contraction occurring in that. It may be arrhythmic or arrhythmic and given persist during sleep and not usually stimulus sensitive. In the case of the other spinal myoclonus is the proprioceptive myoclonus or propriospinal myoclonus. The propriospinal myoclonus, it involves the spreads from the axial along the axial musculature, not affecting the limb. Segmental myoclonus can be anywhere, maybe in the upper limb, maybe in the lower limb, maybe in the trunk. But here only the axial muscles are affected and it spreads from the neck downward like that because the activity spreads along the propriospinal pathway, which connects the inner segments throughout the spinal cord. So both the spinal myoclonus, one is, the pattern is different.
So orthostatic tremor is not a type of propriospinal myoclonus.
No, it's not a type of propriospinal myoclonus. No.
Okay.
Can we try sodium valproate?
No, in fact, I don't know whether they respond or not. I have not tried because Respect safe clonazepam, I tried clonazepam, they did very well.
So the tremor and myoclonus both are the same spectrum or same spectrum?
Same spectrum. I can assure you it is same spectrum. Because see, many of the so-called orthostatic tremor, they say it's very high frequency, more than 14 hertz. Some of them are not that high frequency. Then what do you call the orthostatic tremor? And you look at the tremor now, some of them are very coarse and low frequency, especially when bending. They're called orthostatic myoclonus. But both respond to the same treatment. So it's not, not a practical utility to differentiate whether it's orthostatic tremor or myoclonus, except for the frequency spectrum is different. For a practical purpose, it's almost the same.
Beta blocker is not of use.
No, they tried
So
beta.
how long do we have to give?
How long?
How long we have to give this clonazepam?
Continuously.
How long?
I don't know. I got so many, many, I know it's not so many patients on orthostatic tremor or received taking these medications for months together. After some day, they don't come for follow-up because they know they whenever they come, I will not stop it. The moment they stop it, it comes back again. So they have to continue on that.
Okay, sir.
Sir, in the last case, suppose if the patient is a male, can we consider a fragile X syndrome, tremor ataxia syndrome? Suppose that first case.
No, all this you can think it's a tremor-like movement, but
No,
actually,
no, sir. My question is about that first patient who had a Friedreich's ataxia.
Oh, you mean that patient? Yeah, right. That one. In tremor ataxia syndrome, what is most prominent feature is the tremor. They got a rest and action term. Unlike what these patients have only incoordination. If the tremor is dominant, ataxia is less. The tremor ataxia syndrome is Fragile X syndrome is a strong possibility. Phenotypically, tremor will be dominant.
Okay, sir.
And they can have associated abnormalities in MRI showing the pontine hyperintensities and other macro orchidia and things like that, cognitive impairment. So those things, some of them need not have cognitive impairment. In young children, they can have macro or large testes. So these other features will be there. But there are sometimes Fragile X syndrome can present only with tremor and ataxia without anything else. Because the genetic expression may be very, that's why the phenotypic expression may be very. Okay. Shall I go to the next case or?
Yes, sir.
Any other questions? Okay. Now, this case was initially referred to me in 2022 by Dr. Jidin. Because this patient is going to follow up, that is why I brought the case also. This is a 68-year-old lady. Her complaint started in January. This is a long case. January 2022. As imbalance while walking, which improved in 2 to 3 days' time. We did not know what all things happened at that time. During this period, patient needed support for walking. No upper limb or canal symptoms at that time. 2 weeks later, patient developed unsteadiness in walking again, which improved in 24 hours' time. Patient remained asymptomatic for the next 1 month. By mid-February, patient noticed dysarthria, which also improved partially in few days' time. This is all the past history. On March 1st week, patient noticed dysarthria and difficulty in swallowing and feeling of something sticking in the throat. 1 week later, she noticed paresthesia of the left hand. Subsequently, again 1 week later, patient noticed difficulty in lifting a left arm, which progressed to the extent of total inability to lift her arm for the last 2-3 days. She also noticed difficulty in wringing clothes with the left hand, and dysphagia and hypotonia for the last 2 days. So this is a long story. I'll go back to the history once again. In January 2022, patient was seen here on April 22. That is 4 months back. Imbalance while walking, which improved in 2 to 3 days' time. During this period, patient needed support for walking. 2 weeks later, patient again developed that improved. Patient developed an unsteadiness in walking again, which improved in 24 hours' time. Patient remained asymptomatic for next 1 month. By mid-February, patient noticed dysarthria, which improved partially in few days' time. That is 1 month later. On March 1st week, that's on the 3rd month, patient noticed dysarthria with difficulty in swallowing and feeling of something sticking in the throat. 1 week later, she noticed paresthesia in the left hand. Then again, 1 week later, by the middle of March, patient noticed difficulty in lifting a left arm, which progressed to total inability to lift the arm for the last 3 days. She also noticed difficulty in wringing clothes with the left hand. Dysphagia and hypotonia for the last 2 days. This is the patient seen here on April. So this is on examination. Pupils normal, extraocular movements were all normal. She had bilateral orbicularis oculi weakness, not gross. Overfacing movements were normal. Just the right half of the tongue. You can see the right half of the tongue is there. Foundation was not slightly abnormal, but palate was moving normal. She had mild weakness in the neck plexus, but neck extensions were normal power. No normal or hypertonic. She had weakness of both the deltoid, more on the left side. Both biceps are also weak, more weak on the left side. Biceps were, however, normal bilaterally. External rotaries were weak bilaterally, more weak on the left and the right side. Internal rotaries are relatively good power. The wrist, this extension was normal. Actually weak on the left side, normal on the right side. Brachioradius was normal. On the left side, it was weak. Normal on the right side, left side. Finger extensions weak bilaterally, more weak on the left side. However, more weak on the left side. Finger flexors normal. On the left side, finger flexors are also weak. Flexor pollicis longus was weak. So also extensor pollicis longus. The right extensor pollicis longus was weak, but flexor pollicis longus was normal. It is normal. The small muscles were relatively good for mild weakness or bilaterally or but more weakness at the proximal. That is weak. Performance is positive on the left side, but not severe, not a severe. From the lower lip, hip flexors were mildly weak. Actually, mild weakness if at all present. Knee exercises were also mildly weak, but normal. Because she could overcome my hand power. Those flexors are weak bilaterally, not very weak, very mild weakness bilaterally. Anteroflexion was normal. Abductors, adductors are also normal. The hip flexors also appeared. Reflex the upper lips all absent. Knee jacks were also absent, but ankle jacks are well present. Just a little. Compared to the other reflexes, not really elicit. Not it. It's very elicitable to ankle jack. Pandarus flexor. Statistics examination is actually normal. You said yes, it's able to feel. You said correctly. Again said correctly. There's no nerve thickening.
Amazing.
She could get up from the stool without any problem. efficiency weakness is very, very mild effect on it. And those folks appeared weak, but she could stand on feet and toes. So respiration weak may be quite mild effect on it. And approach was good. Proper was negative. So an examination, cranial nerves, weakness of both orbicularis oculi, lower facial appeared normal. Right element, 12th cranial nerve palsy. Weakness of neck flexes, extensions appear normal. Motor system examination, tone normal, no wasting. Our left upper limb, weakness of left deltoid, biceps, external rotators of the shoulder, brachioradialis, wrist extensions and wrist flexes, finger extensions and finger flexes, flexor pollicis longus, extensor pollicis longus, and intrusion. The right upper limb, weakness of right deltoid, biceps, external rotators of the shoulder, finger extensions, extensor pollicis longus, and mild weakness of the intrusion. Lower limb, weakness of both hip flexes, Corini extends hip flex, I'm not very sure about it. Mild weakness of both dorsal flexes was there on lying down examination. Data all absent except angle jacks which are well elicited. Plantar ongoing, sensations normal. So where is the localization and what's the possible etiological diagnosis?
Muscle disease, muscle because I
CADP, sir.
Okay, CADP.
Mononeuritis multiplex. Mononeuritis multiplex.
Okay, very good. Okay, so this is what he said is correct. Maybe mononeuritis multiplex. Why not polyradiculopathy?
Also possible, sir.
It's also possible. Anything is asymmetrical type of polyradiculopathy. Mononeuritis multiplex is another possibility. But here, only thing is that the sensory system sensations are all spared. It's CADP of previous sensation. You can appear CADP is there, but not very common.
muscle disease, sir.
Muscle disease is unlikely because look at the pattern of involvement. There is no selectivity involving all the muscles, the upper and lower limb, and reflexes are all absent. The upper limb, except the angle jack. Muscles less affected is angle jack is even the muscle bulk is good, but the reflexes were lost.
Neuromuscular junction, sir.
Pardon?
Neuromuscular junction.
Again, action represents again neuromuscular junction. Absence of wasting is favoring, but action reflexes cannot occur.
Limbs, sir. Limbs.
Limbs is a possibility which can think of that possibility.
Sir, initially symptoms are episodic, especially bulbar symptoms. Then some infiltrative disorders.
Pardon?
Root infiltrative disorder, sir.
Yeah, that could be, that's called a polyradiculopathy. So when you get cranial involvement along with spinal motor system involvement, think of one possibility. It's a polyradiculopathy, where the involvement is meningeal disease, which can affect the cranial nerves as well as the spinal roots. Like as you correctly said, like sarcoidosis, lymphoma, or those conditions can, or even chronic meningitis like tuberculosis, can affect the meninges producing multiple radical as well as cranial nerves. The disease in the meninges. So it's a good thought. That's the thing we are keeping. Patient brood, maybe patient that might have improved, as you said correctly. But the localization is either in the multiple roots, that's a strong possibility because cranials are affected, or multiple nerves. We do not know where it is affected. Correct? But curiously, it is affecting only the motor nerves. So it's not a classical mononeuritis multiplex of what you usually think about it. For example, you get mononeuritis multiplex, especially sensory also to be affected. Like for example, if you think of a vasculitic etiology or other etiology like diabetes or neurofibromatosis or paraneoplastic, why should sensory should be spared? That's slightly odd. Or you have to think of immune-mediated disease where the motor system is predominantly affected. Sensory may be there subclinically, like for example, multifocal motor neuropathy or multifocal axonal motor fighting. But the motor nerves alone may be affected first because of the selectivity of the immune-mediated attack on the motor nerves, sparing the sensory nerves. That's possible you have to keep in mind. Because whatever the motor nerves affected also motor, the facial as well as the 12th nerve is also motor, no sensory. This is a possibility you have to keep in mind. In infiltrated disease in the meninges, again, the odd point is that purely motor, no sensory. Then if the roots are affected, why it's became only pure motor roots? I agree with you that possibility can be ruled out, but that makes it a little low in the list. So this pattern, whether it's a radiculopathy, whether it's a multiple nerves, speaks for a immune-mediated disease. Because whether demyelination or we don't know, but immune-mediated because it's affecting only in the motor nerves, all motor radicals. Otherwise, you want to think of a muscle disease or meningitis, as you said. Okay, so these are the possibilities. So I thought possible motor is multiple suffering the motor nerves, multiple radiculopathy with pain damage. These are the two possibilities I also thought.
Sir, was there any muscle wasting of fasciculation?
No wasting of fasciculation.
And the right tongue side, right side of the tongue is wasted asymmetrically.
Yeah,
That,
I'll tell you, the problem with the tongue is that even if you get a 2-day history of element weakness, the tongue may appear wasted. Remember, take my point, appear wasted because the longitudinal fibers are affected, the tongue will become corrugated. So some hollows will be there in the tongue, which may spuriously diagnose element wasting. Don't diagnose that because the longitudinal fibers are affected, the tongue will shrink and become more bulky and shrink and with the corrugation of the surface. So erroneously, one may think there is wasting. So that wasting part again little odd, and the complaint is only 2 or 3 days duration before she came to us.
so the orbicularis occlusive weakness is rather odd for CIDP, sir. Orbicularis facial.
Facial involvement, bilateral facial involvement.
Okay.
Now these are the ways patients comes to you, So let us see what investigation was. It was already patient undergone 2 nerve conduct studies before. First about 2-3 weeks after the onset, that is January, that showed all contractions were normal except low amplitude at right perineum. Distal latency was normal, contraction velocity was normal, amplitude was only low in the right perineum. See, here again, you should remember that the conduction in the upper limb, we are doing only the median and ulnar. Those muscles are relatively spared, more involvement for the postural muscles. Anyway, then the sensory potentials were all normal at that time. SNAP was normal, even the lower limit was normal. FM studies was also normal. So the only abnormality was decreased CMAP and mild decrease in the velocity in the right convolution. So what does that favor?
Demyelination.
Correct. Yeah, correct. You have to suspect proximal demyelination is one possibility you have to strongly consider. Okay.
Sir, but triceps not done now, sir.
Pardon?
Triceps nerve conduction. Radial nerves.
Perfectly right. We should expect it right. Radial nerve conduction is what we expect because that is a maximally affected muscle. But when you send for conduction, they do only the routine some nerves. So this conduct study was done from outside. The patient came to me only on April. This is done on January. So I'll come to that later. What is it is correct. Let us see. The radial nerve is very, very important. So second conduction was done on February, 1 month later. At that time, what happened? The right peroneal has become little more low amplitude. Just now, left peroneal got affected. The amplitude became less. Okay. The FAs were normal, except that the left peroneal FA was prolonged. Sensory potentials were decreased. Sensory potential, the right sural and both the superficial peroneal become slightly less. We can't say it's grossly abnormal. Maybe technical or fault also could be a possibility. If I had been absent, I would have been happy, or less than 5 would have been happy. So, a mild decrease in the sense time. So, we should not put so much of weight on the sensory potential if it is mildly lowered. That is the second one. So, it is the disease slightly progressing as affecting the other conperoneal also. So, decrease CMAP amplitude from both CPN. Mild decrease in SNAP from the sural and supraperoneal could be significant. But one nerve showed disproportionate prolongation of the FA blade. See, that is slightly odd. See, for example, see this one. See, 79.70 left peroneal. But the distal latency of the right and both were not much affected at all. See the distal latency. And the velocity is also almost not much affected. At the same time, FA latency disproportionately prolonged. That again points to what? A proximal affection. Okay. So third NCS was done on March, and again after 6 weeks. This showed that the peroneal potential become much more low here. But I can look at this. Distal latency is normal, and the conduction velocity is normal. Okay. But the amplitude is low. If it were a proximal demyelination, why should the amplitude be low? That has become low in the both. From the very beginning, that amplitude remained low. The median latency prolonged, ignore that, many people will have that. And the FA latency, which is prolonged initially, has become not present in the subsequent study. The sensory potential has improved or maybe normal. Even the third NCV shows the normal sensory potential, making you think that the previous SNAP abnormality might have been wrong. A mild decrease. So you have to take that may not be very significant. So for sensory potential, for our practical purpose, you have to take it as normal, not present. It's a disease affecting purely motor nervous system, not the sensory. So this is the third NCV by which patient came. Showed the CMAP amplitude remain low in both CPN, normal SNAPs. Then this is the fourth NCS which was done here after I admitted the patient. Till now, what do you think? Still, it goes for a demyelination itself because he has got significant weakness of upper limbs. But at the same time, the reflexes are absent. But you find the motor potential, except that CMAP, decreased CMAP amplitude, other CMAP amplitude is normal. So what do you think? Maybe proximal demyelination thing. Except that you can't explain the decreased CMAP amplitude of the both convener. That also can be explained because if you got a distal conduction block, the block is distal to the distal stimulating point, you get lower CMAP amplitude. The velocity is normal because the proximity to that nerve is normal. FA latency is normal because proximity to the FA conduction is normal. The block is distal, you get only decreased CMAP amplitude, which can be confused with axonopathy. Now, this last CMAP, this was done in this hospital, showed that there is again decreased CMAP amplitude, but the amplitude on the left peroneal is slightly more better than compared to the other one. But remember, the velocity is normal, distal latency is normal. Left median also the amplitude is come down. And here we did all the studies. You find that this left ulnar is affected here. Radial was affected on the left side. That is the maximally affected, and now on the left side, the finger is everything was weak. Left axillary was affected, and left muscular cutaneous also affected compared to the right side. On the right side, the amplitude is decreased in almost all the nerves in the left upper limb, muscular cutaneous, axillary, left radial, left ulnar, and left median also. So all nerves are affecting the left upper limb. The right upper limb, we got initially upper limbs are normal, but the lower limb, the both peroneal, the left right peroneal FAV is absent, left ulnar FAV is absent. And coming to the other sensory, left ulnar sensory potential is absent. All other sensations are preserved. See, previously left ulnar snap was normal. Now it has become absent on the fourth NC study, but all of the snaps are normal. Okay. Amplitude is decreased on all the nerves on the left upper limb. So how do you interpret all these NCV studies? So last one, decrease EMAP amplitude on the both conperoneal nerve, left CPN, left ulnar, left radial, left axillary, left musculatus nerves. FF absent from left ulnar and then peroneal. That we expect maybe due to the low CMAP amplitude can be absent, as you all know. So snap absent. That one is odd man out is that the only snap abnormality was seen in the left ulnar, but previous records show that was normal. See, is it technical or something else has happened on the nerve? We don't know. No, what do you think?
Sir, what about medial nerve, sir? Distal latencies are prolonged, no, sir?
That element we did not give much importance because in a minute time these people get unrelated carpal tunnel syndrome. So that distal latency prolongation alone don't take it significant. Many old individuals can have that carpal tunnel, especially females.
Radial F was done, sir.
Sorry, MMNCP, sir.
F of radial.
Yeah, let's consider, but MNC problem, you have to show a contextual block. Okay, but I'll come to that point. Okay. Bruce, what was you asking?
F of radial F latency.
I'll show. Let me see. That was not done. FA was just not done. But that potential is already low. CMAP amplitude is low on the left side. So what will be the interpretation here? So what I would think, this sensory potential action on the left ulnar, I will keep it separate. But there is an odd man out because all of the nerves has no sensory potential normal. That the previously also that sensory potential was well preserved. So suddenly that became abnormal in the last NCS. So something else, either technical or something else has happened to that arm, you have to keep in mind. Forget about leave it, leave about, separate out the ulnar snap. What about the abnormality? Real abnormality in hemios is motor weakness. And even some motor abnormality in the conduction. So you have to interpret that thing. Patient has no sensory loss, and the patient's got snap absent does not give much importance to our diagnosis. So is it an axon involvement, or is it something like a demyelinating conduction? That's my question.
Demyelation.
Yeah, if you look at the NCS studies, look at axonopathy.
Demyelinating, sir.
Why demyelinating? See, look at the NCS. Amplitude is very low. Velocity, distal latency is normal. Conduction velocity is normal. The previous
if that conduction block is proximal to the area where we are putting the electrodes,
yeah,
then the CMAP will be low only.
No, why should it be low? It will be perfectly normal. See, if the block is proximal to the stimulating electrode, you will see CMAP will be low. But if the block is distal to the distal stimulation, correct?
Yes, I mean distal.
Correct.
Distal, yes.
Perfect, right. So the possibility, yeah, exactly. So possibility is something like a nodopathy like thing where the block is distant.
Yes.
Yeah, where you can have a normal latency, normal conduction velocity, but CMAP amplitude may be normal. So sorry, low, where the block may be distant. But the question now comes, can you differentiate maximopathy? So when if I say it's an axonopathy and not distal conduction, how to disprove my point?
But if it is axonopathy, the first conduction, if we take the sequence of conductions, when the patient was having weakness, then also the CMAPs was normal in some, but of course, radial was not done in the first.
First time, yeah, radial was not done at that time. Moreover, the disease is progressing, no? When the disease is progressing, CMAP progressively become less.
The axonal, this time, by that time, April 2022, if it is a progressive axonopathy with weakness, yeah, the patient would have been more wasting and more.
Yeah, you got a point there. That's the point I wanted.
Yes.
That's the point I wanted to tell. I'll come to that point later. So it means that somebody very difficult to differentiate between a distal conduction block versus an axonopathy. So when you get a demyelinating type of distal conduction block, usually get distal latency prolongation. You got the point. See, it's a demyelinating problem causing a distal conduction block. Expect some distal latency prolongation also, unless it's a nodopathy. In nodopathy, you won't get any distal latency prolongation or a conduction velocity prolongation. In a demyelinating pattern of involvement, if you get a conduction block there, see, you can expect that. So uniformly, that area alone is lost is very unusual for demyelination. Usually it associated with some demyelinating changes in the rest of the nerves also. Is it not common sense? So you get a prolongation of the distal latency. It's a demyelinating type of conduction, right? But in nodopathy, you can have decreased amplitude without any prolonged distal latency or a conduction velocity. That is one point. But as you said correctly,
why is it, sir? Why is it, sir?
Pardon?
Nodopathy is a distal problem. Why that is not causing a distal latency?
Because in fact, I had taken that class little earlier. I'll tell you once again. See, this is one nerve, and if there is no node of annuary, the impulse is jumping from one node of to the other. If there is a block is occurring at the node of annular, the rest of the internodal region is normal. Okay, so that part is conducting normally. Suppose you got a nerve here, one node is affected here. The impulse will not transmit from that area across that node. So that area, the amplitude will drop down. But to stimulate distal to that area is normal. That myelin sheath is normal. So distal latency is normal. So proximal to that, again, the conduction velocity will be normal. Okay, in demyelinating disease, pure demyelination, why should it only produce a focal demyelination in one area? If that is so, it can behave like a nodopathy. Nodopathy is something which is occurring only that block at one particular point. Demyelination means it over a length of the nerve. The length of the nerve is also affected. Naturally, expect either a distal latency prolongation or conduction prolongation depending upon where the demyelination is occurred. That is why nodopathy, to diagnose nodopathy, you can have decreased amplitude or even a normal amplitude if it is proximal stimulation, or a typical conduction block, proximal distal, but velocity should be normal, conduction velocity should be. Okay,
and this can explain the sensory lesser. That can explain the not involvement of the sensory, because nodopathy means sensory, sir.
Nodopathy can also affect sensory part of it. That's not against, but usually the mind.
Okay.
Yeah. So what test will you do to differentiate whether it's an axon or common garden question, axonopathy, decreased amplitude, or a distal contextual block due to neuropathy. What test will you do?
Denervation potential.
Very good.
Yes,
So you did. So this is the possibility now after the NCVs. NCV study, last NCVs. One is multiple saphenity, mainly the motor nerves, like multiple motor neuropathy, like this thing. If it is axonal, or multiple radiculopathy cranial affection, also possibility. We cannot rule out that possibility because sensory potential is pain. Odd point is absent sensory ulnar. The ulnar part I don't consider here at the point of time. So we need a CSF study, correct? CSF was done already, outside normal. That speaks little against a polyradiculopathy. Okay. Now, other investigations done. I think these things are normal. Blood parameters, SCOT, liver function, everything normal. ANA profile was done. Serum protein electrophoresis is done. They're also normal. ANA profile, serum protein electrophoresis, immune electrophoresis, all were normal. And MRA, they came with MRA, brain and spinal cord. That's also normal. Mammography was done. So what do you want to do now? Now the question is it something like a chronic variant of a man, like CAAN? Or could it be nodopathy with a distal context? How to differentiate it?
NMG.
Correct. You have to do it because if it's a chronic amount, definitely you expect a denervation potentials. If it's a nodopathy, you don't expect a denervation potential.
Yes,
yeah. So that's the thing to do that. And one has got a good prognosis, other has got a very poor prognosis. So what is the clinical, as Bindu was telling, the clinical point favoring distal conduction block is the no wasting. So what test will you do? EMG the affected muscles. So due to the EMG for the various muscles, for the ADM, there is no spontaneous action. This thing is activation, but there is not enough. Then left deltoid, I'm choosing the affected. Again, no denervation. Activation is decreased. FDA on the left side again. It needs to look like wasting, but actually not a real waste. Again. So any other test you order for nodopathy, so anti-ganglios antibody burst and which came as negative, which may not be possible all the time, positive all the time. So next question is, can be additional meningitis possible except for the absent snap in the left leg? That we are taking it out. So but all other snaps are normal.
Sir, electrophoresis immunofixation?
Done normal. I showed that thing just before. Immunofixation was also normal.
Okay, sir.
I'll show that one second. That's one. Now, what will you do in this patient? What is the troubling thing is that she's got an absent snap and the ulnar snap. Is there something? Some other reason to explain for the absence. So that's the next thing you have to keep in mind. So I checked the potential bent and checked the snap is really absent. It was not there initially in NCA study done earlier was normal. So here we did just abnormal. So I thought whether it's a technical problem So I went and asked the patient, asked the technician to do it again. That is really absent. So then what will you do? Look for any other cause for his somnana report. And if one, yes, but increased carrying and compared to the right.
So this is definitely more on
It's more carrying. Probably that such chronic stretching or pressure palsy on that side had caused this absent snap on the left side. Probably. That's only explanation. The CSF was already done. Repeat CSF is also done because the possibility of polyradiculopathy cannot be totally ruled out now. But the point strongly again is the absence of innervation favoring in nodopathy. So MR with contrast already done 3 weeks back, so I did not repeat it. So patients put on IVMD for 5 days and responded remarkably well. Then this is follow-up after just one. Okay, I'll call you. This is follow-up after 1 month. I think in the interest of time, I'll run fast forward. She became much better. And this is after 2 months. And this is the last follow-up. Follow-up for just 1 week back she came. It's every muscle power is known. This is both third follow-up also much better.
Sir, after medial prison, you gave white launches.
Well, she was on mycophenolate. 2 gram PD. Followed putting simultaneously steroid and mycophenolate. Steroid gradually. Steroid has become good power. Ice has become good power. Ice has already become. They all been improved. And again become normal. I think I'll skip all these things. Everything or reflexes remain the same. And she was able to. Last exam February 2023 was totally improved, no weakness of any muscles. So that's the story. There's something mimicking like something like a multifocal motor axonopathy, but she did very well on steroid and things. Most likely some kind of a chronic nodopathy like presentation.
Sir, what do you give steroids and IVIG, sir?
No, not IVIG, IV methylprednisolone.
Only. No plasma.
No plasma, IV methylprednisolone. And then along with that added mycophenolate because it's coming repeatedly. If you go back to the history again, even the 2-3 episodes which I had earlier also responded with, see, 2 weeks she became normal. That's history she gave. That means that the doctor must have previously given steroid and the patient responded. So that's another clue to suspect that patient. This patient also will respond to steroid.
One of the event was very brief, no, sir. 24 hours only.
Right. Correct. 24 hours only. I do not know whether that story is correct or wrong. Because we have not seen the patient that time.
What about the cranial nerve, sir?
Cranial nerve is got, it is affected here. Again, that's also part of a nodopathy process.
Should we look for a paraneoplastic edecyte, sir?
Yeah, that's a possibility you have to strongly consider. Again, see, this I'm not sure whether it's a truly nodopathy or it's kind of a focal demyelination occurring, we don't know. Even the cranial is also new, that part, demyelination is affecting that part again, we don't know. But that is affected.
Sir, after 5 days of methylpred, if we give monthly pulses, especially in those with comorbidities.
Yeah.
Will that help in CIDP?
Yeah, in the CADP, the response is highly variable. Some of them, they do respond with only oral steroid, they do very well. Some of them, whatever you do, I've seen patients when I was in Amrita, the patient could respond only to weekly, only to what you call it, tuximab, repeated tuximab. Plasmapheresis failed, IVIG failed, then you have to go for tuximab. Okay.
Nodopathy tremor may be sometimes very prominent. Tremor.
Yeah. Yeah. That is amine variety. Yeah. That's correct. So, any questions? I will stop. Shall we stop?
Okay. Good night, sir.
Sir, good night,
Thank
sir.
you.
Good night.
Good night. Good night, sir.
Good night, sir.
Good night,
Thank
sir.
you, sir.
Good night, sir.
Good night. Good night.
Good night, sir.
Good night, sir.
Thank you.
Night. See you next week.
Good night, sir.